Good morning, everyone. Today I'm going to be talking about functional appliances. Functional appliance is an appliance that is going to use, eliminate, or guide the forces of the muscle, tooth eruption, and growth to help correct malocclusion. At first, the idea was thought up by Pierre Robin to use an appliance to help severe retrognathic mandibles in babies and compromised airways, to protrude it so it can take a more suitable position. And thus he created the monoblock. Later on, Viggo Anderson combined Pierre's idea with his activator to form the first functional appliance. As seen here is the monoblock created by Pierre Robin, and here is the Anderson activator created by Viggo Anderson. How exactly do functional appliances work? This topic is very debatable among orthodontists, as it is not really sure or certain if these appliances have an effect or if it's just the natural growth of the patient itself. Now, in animal experiments, there have been shown to have skeletal structural change. However, these results can't be really trusted, as animals have different morphology than humans, as well as the appliances used here were all fixed, unlike the removable ones that may be used for a human or a patient. Later on, clinical studies were made by randomized controlled trials that showed that the most prominent changes caused by functional appliances was from the dental alveolar changes. In this change, it showed that there was distal movement from the maxillary teeth and mesial movement from the mandibular, along with the tipping of the upper incisors palatally and the lower incisors labially. Skeletal changes were minor, as seen as condylar cartilage growth, anterior migration of glenoid fossa, slight maxillary restraint, mandibular growth, and lower facial height increase. Sadly, changes were too small to replace orthognathic surgery in severe skeletal discrepancies, but even though there were a number of cases that had little changes, there also showed a number of cases with extensive skeletal change. And this may be why in some patients, the progress seen is very rapid, while as in others, it is very limited. Even with the use of a functional appliance in severe discrepancies, there's sometimes a major improvement of 20 to 30% chance. And if that occurs, it will still likely need camouflage or orthognathic surgery later on in life. Now, when timing the treatment, it should always be done during the growth phase, and most preferably during the growth spur. This can be seen as a rapid change in height or a maturation in the cervical vertebra by the lateral skull radiograph. Usually, the C3 and C4 of the cervical vertebra are shown to have characteristic maturations. When timing for the treatment, as said before, it's going to be during the pubertal stage or the growth spur, and during so, you will have a mixed dentition. You may either do an early treatment, so you're going to have treatment in the early mixed dentition or in the late mixed dentition. If in the early mixed dentition, patient is usually younger than 10 years old, you're going to have two phases, the initial phase and the second phase. In the initial phase, you're going to use the functional appliance until the adult dentition needs to erupt. So you're going to withdraw the appliance and allow eruption to occur. And then afterwards, you're going to begin the second phase of placing the fixed appliance that is taken over by a specialist. Now, disadvantages is that an early mixed dentition treatment, there's going to be a longer treatment period, as well as it being more expensive and being a greater burden on the patient. However, certain times the patient is affected psychologically and negatively by their appearance. That may be due to social standings or self-esteem. So it's very important to begin treatment early in order to boost their confidence and reduce the negative social standing. In late mixed dentition treatment, there is a positive side that you are able to immediately place a fixed appliance due to the sufficient eruption of the definitive adult dentition. Either way, early or late treatment, they are both successful in increasing overjet correction with no difference in degree to the skeletal change or the quality of the final alignment. It is generally more acceptable for the treatment to begin during the late dentition. However, as I said before, if the appearance of the malocclusion is affecting the patient psychologically and is having a negative effect on their surroundings and actions, then it's best to start with early treatment. Main indications for a functional appliance is Class 2 malocclusion, specifically Class 2 Division 1, but modifications can be done to allow Class 2 Division 2 treatment. In Class 3, treatment with specific functional appliances can be done, but the skeletal correction cannot be made, and it is best to have orthodontic camouflage later on by a fixed appliance. Now with Class 2 Division 1 malocclusion treatments, the arches are going to be well aligned. So the only problem is the anterior-posterior discrepancy, and only the functional appliance may be needed. The slight overcorrection of the occlusion is helpful to reduce relapse, and later on, the appliance may be used as a night guard or used nightly until the end of the growth period. When correcting the skeletal discrepancies, the process is known as growth modification or dentofacial orthopedics. The functional appliance can sometimes cause tilting of the teeth, and so a portion of the correction that occurs is actually orthodontic camouflage. To Division 2, using a functional appliance before a fixed appliance may be more efficient in treatment later on than fixing it with only a fixed appliance. The Class 2 Division 2 incisor relation is transformed or reformed to a Class 2 Division 1 and then continued to be treated with a functional appliance. Now, the appliances may be modified in order to procline the retroclined incisors and help improve incisor relationship. In addition to the monoblock and the Anderson activator, the types of functional appliances also include the twin block appliance, the Hertz, the medium opening activator, the bionator, and the Frankel appliance. Now the twin block appliance is a two-part appliance with an upper and lower part that are connected by interlocking the posterior bites blocks. The bite blocks are at least 5 millimeters high to ensure that when the patient bites, they don't bite with them on top of each other, but rather they bite so that the mandible is protruded forward and the lower bite block is in front of the upper bite block. This appliance can be worn full-time and sometimes during eating, and it can also be modified to expand the upper arch, such as in Class 2 Division 2 malocclusions. And a great advantage is that it can be reactivated during treatment if there is a need to increase the posture of the mandible forward. A downside to this appliance is that a side effect after use is that there are bilateral posterior open bites, and this is due to the lower teeth not being able to erupt from the upper bite blocks that block their way. And so a quick way, an easy way to fix this is by shaving off a bit of the occlusal part of the upper bite block so that there is some space for the lower teeth to slightly erupt and allow fixed application and a fixed appliance later on. Now, when looking at this picture, you can see in the lateral view that the bite blocks interlock with each other. And as said before, the upper bite block blocks the lower teeth from erupting properly. So even though the anterior may be closed later on, the posterior will be left open. As well as a modification can be done to the inside, such as this spring to push out the anterior teeth. As seen here, there is an arch expander by using a midline screw in the upper tooth with a twin block. And here you can see there is a new acrylic being placed to reactivate the appliance and to increase the posture of the mandible more forward. The Herbst appliance is also a two-part appliance with the sections being attached to the buccals of the upper and lower teeth and then joined by a rigid arm. Now the appliance is fixed, so it ensures that the patient is wearing it and following instructions, and that the mandible is pushed forward whenever closed. Now the Herbst is less bulky than the twin block, and it's much more easier to eat as well as talk with it, so patients find it more comfortable. However, a great disadvantage is that it has a higher risk of breaking and a higher cost. Here, the Herbst functional appliance can be seen to have the rigid arm, as said before, and being fixed to the teeth like crowns. Now, whenever opening or closing, the arms will move along the screw, but they will not allow the mandible to go backwards. So it will always be in a protrusive or a anterior posture to the mandible. Now, as you can see, it's less bulky than the twin block as before. The medium opening activator, or MOA, is a one-piece functional appliance. It has a lower acrylic extension lingually for the labial segment only. And the lower is connected to the upper by two posts of acrylic that allow a breathing hole interior, so that the anterior part is left open. A great advantage of the MOA is that it has minimal acryl, so the comfort is improved, as well as an important feature that the lower teeth are not capped, so that their eruption is unimpeded. They can erupt and they will reduce the risk of having bilateral open posterior bites. Thus, it is perfect for reducing deep overbites. Here you can see that the MOA is one part consisting of a lingual extension and a labial extension only from the anterior, as well as having two columns, as said before, to connect to the upper part, and no capping of the lower side teeth. When placed in the mouth, as you can see, there's space for the lower teeth to erupt and close off any open bites caused by malocclusion. Lastly, you have the bionator and the Frankel appliance. Now, the bionator was originally to prevent the tongue from moving around too much, to modify its behavior. But later on, they discovered that the tongue really didn't affect or cause the malocclusion as much as the skeletal description did. And so it became a means to allow arc expansion as well as mandibular protrusion or posturing the mandible forward. A great advantage is that it has no palatal extension, so it's very comfortable to wear, and that the buccal extensions of the labial bow prevent the cheeks from touching the teeth and thus permitting the arch to expand slightly. Now the Frankel appliance, I say now too much. The Frankel appliance is very مميز. That it is a completely tissue-borne appliance, and it has many variations to suit the range of malocclusions. It as well posturates the mandible forward and has buccal shields that help stretch the periosteum. The only problem to this appliance is that to wear it and to repair it is very troublesome and problematic, as well as it being expensive to make, so it's not commonly used. And it's practically, people stopped using the Frankel appliance practically. Here you can see the bionator and the Frankel. They are very similar as they both prevent the cheeks from touching the teeth and allow a certain degree of expansion in the arches, as well as the palate not having any acryl, so it's much more comfortable for the patient. Now that we've understood how a functional appliance works and when to use it and what kind of appliances there are, we're going to talk about the clinical management, beginning with preparation. You're going to first take an outline impression and make sure that it is well extended to include the tissue, because you may use an appliance that is going to affect the cheeks, as well as a bite record with the bite being in the desired anterior mandibular position. The bite itself is going to take the 3 dimensions: anterior, posterior, the vertical, and transverse to be correctly transferred. And the degree of the protrusion itself is dependent on 2 factors: the overjet size and the patient comfort. If the overjet is too large and the protrusion has to be more than 75% of the maximum, then the patient is going to be very uncomfortable and he's not going to tolerate, or she is not going to tolerate, the appliance. Now the protrusion itself can be done incrementally or one shot, all in one go, just immediately to the place that you want. But it's more preferably for the patient, especially for comfort, to do it incrementally by reactivation. And in the end, the result is the same. It will be successful either way. Now that you've prepared, you're going to do the fitting, you've gotten the appliance, you're going to make sure that the patient is aware that there must be a period of discomfort because they are moving their mandible in a position that they are not used to do, and for a long period of time as well. So ensuring that the patient knows that they should still have higher morals and should comply to wearing the appliance is very important, so that they can in the future see a difference. This will also help them in adapting to the appliance much more easier, and it is seen that in children they are able to adapt much more quicker if the appliance is worn properly than adults. Now, depending on the appliance, it can be worn in various hours or various durations, but it is most effective if it's worn at least 14 hours a day. However, some appliances can be worn throughout the whole day, such as the twin block and the herps, and this makes it much more faster for the patient to become comfortable and adapt to this appliance. The patient should now have the appliance and be using it correctly as instructed. And so you should have a checkup every 2 to 3 weeks or 1 to 2 weeks to review their motivation, their compliance to the appliance, the fit of the appliance in the teeth, and the progress of their treatment. After you're sure that they have been following your instructions and as you can see progress in them and you are certain that they will keep on following the instructions, you can increase the duration of the intervals to 6 to 10 weeks. Now, if there seems to be a problem with the progression, if it's slow or you just don't see any progress at all, it may be because either the patient isn't following instructions or there is a lack of growth or unfavorable growth rotation, that the appliance isn't placed correctly, or there is a problem with the appliance design or fit itself. The most common problem being the poor compliance is the reason. And after 6 months, if you still see no progress, then you have to stop the treatment. You have to reassess the whole plan, make sure that there is not something you have missed, and redo the whole treatment. At the end of the treatment, the overjet should be edge to edge and be slightly overcorrected to reduce the risk of relapse. And most functional appliances are followed afterwards by fixed appliances. And this transition is kind of complex, so it's best for the specialist or orthodontist to handle this. And as previously said, if the arches are well aligned to begin with, as in Class 2 Division 1, then the second phase of a fixed appliance is not needed. You only need the first phase, and they can wear their functional appliance later on during only the night and until the growth period stops. Now, the average rate for failure of a functional appliance is about 20%, and this 20% failure is mainly due to the poor compliance, as said before, be one of the factors that causes failure or causes there to be no progress in the treatment. Thank you. I am Kinato. Yeah, yeah.